Good morning, everybody, and welcome to this important conversation. I'm thrilled and appreciate the folks at Madison 365, Henry and his whole team, for inviting me to moderate this important conversation around barriers to care. Wisconsin Leadership Summit, as many of you know, is the premier networking opportunity designed, curated, and for people of color in this great state of Wisconsin. Today's session, we're going to be talking about barriers to care, the collateral damage of historic inequities in our state. Today, I'm joined by a tremendous panel of wonderful guests who have been leading efforts to erase and eradicate inequities across our state. First, I would like to introduce Dr. Malika Siker, is an Associate Dean for Student Inclusion and Diversity, and an associate professor in the Department of Radiation Oncology at the Medical College of Wisconsin. Welcome, Dr. Malika. Would you like to share any additional information about yourself?
Sure. It's really just an honor to be here today, and I look forward to engaging in discussion with the other esteemed panelists about how we view care, barriers of care, health equity within this great state of Wisconsin.
Thank you, and thanks for joining us today. Next, we have Kristin Welch. Kristin is the founder and director of the Waking Women Healing Institute. And Kristin, would you like to share a little bit more about yourself?
Sure. Poso mi, good morning. Poso nat timatamo natakam, wapashiani totem, kais mamachito komat nomanewak. So my English name is Kristin Welch. My background is primarily in AODA prevention, youth and family work. Used to be a CST coordinator over in Stockbridge, Muncie. So a lot of prevention work, a lot of healing work. And currently within Waking Women, we serve Indigenous women survivors of sexual assault. And we work with our families of missing, murdered Indigenous women, both in healing and justice issues. But it's really great to be here with such an amazing panel. Looking forward to it.
Thanks for joining us today. Next, we have Justin Rivas. Justin leads the Community Health Initiatives for the Milwaukee Healthcare Partnership, aiming to improve health outcomes and advance health equity through community-wide collaboration. Welcome, Justin. Is there additional things that you'd like to share about yourself?
Thanks. I'm just really glad to be here and excited to have this conversation with all the great voices in the room. And just quickly, in my prior role at the University of Wisconsin Population Health Institute, I had some kind of statewide scope in terms of seeing health equity data, so I think I can lend some conversation to that, as well as working for County Health Rankings and Roadmaps, which is a national program focused on social determinants of health, so lending all those angles, in addition to being a board member on the Wisconsin Public Health Association, so bringing in the public health lens too.
Wonderful. Appreciate you joining us today. Last but not least, a friend of mine, Lisa Peyton-Caire, the founder and CEO, president of the Foundation for Black Women's Wellness, launched in 2012, committed to eliminating health disparities and other barriers impacting Black women and their families and communities. Lisa, thank you for joining us. And is there additional comments that you'd like to share with us at this time?
First, thank you, Madison 365, for the opportunity to be here today in this great forum. To Gabe, who's a friend and a co-conspirator in the work that we do locally, the Foundation for Black Women's Wellness. Our intent is to empower a generation of well Black women, and that commitment sprang from a very personal place for me. It comes from real losses and inequities that we feel and experience in our families, our communities, with our loved ones, my mother and many women and men in my family who we've lost to this battle for health equity and structural racism. So the work comes from a place of knowing, absorbing these inequities that we all are working so passionately to address. And we're proud as an organization to really be expanding our work across the state to really elevate the issue of Black women's health to the level of priority that it deserves, along with advocating for broad women's health and health equity across all of our communities. So proud to be here and among this distinguished panel this morning.
Great. Thank you all again for joining us today. You can see why I'm excited to be up and early this morning on a Thursday morning, despite the rain outside my window, because there is going to be such an enriching conversation from a very diverse background of perspective. So excited to get going here. And without further ado, let's get to the conversation. So again, just to level set, barriers to care, the collateral damage of historic inequities in our community. Before we get into a deeper conversation, I would like to level set and just understand from your perspective, from your background and from the work that you're engaged in over your professional and personal careers, what does care mean to you? And this is a free-flowing conversation, so feel free to jump in, but really interested in each of your perspectives when it comes to the term care.
Well, I scribbled down a definition, Gabe. It's so much the case that we are involved in ensuring that people have care and what that care should look like. But I don't think I've ever been asked to define care. So in my quick self-definition, it is the attention, the support, and the resources necessary for physical, mental, spiritual health and well-being, the presence of that attention, the accessibility of that attention, that support, and the tangible resources necessary for physical, mental, spiritual health and well-being.
Wonderful.
Yeah, that's really, it's parallel to how we as Indigenous women and people view care. It's really holistic. It's your mind, your body, your spirit, your emotional well-being. And we add that layer of land wellness and connection to land. For us, connection to our spirit is our connection to our identity. And that's directly rooted to our origin, our mother, the earth. So if she's not well, we're not well. And, there's this layer of social justice and environmental justice that we look at in terms of how we are redefining care within our work as Indigenous people, sort of decolonizing that version of care. It's a community-based and land-based care as well.
Incredible. Thank you.
It's so great to hear all of these perspectives. For me, when I think about care immediately, I think about, I'm a cancer doctor. So I think about the interactions that I have with my patients in the clinic room, being present for my patients, being able to deliver personalized, state-of-the-art, medical care to help my cancer patients through their journeys. But I know that it's really just, it's more than that. It's, empathy, it's character, it's delivering culturally responsive care, it's responding not just to the disease, but all of the elements that give into the disease. In my other role, I'm an educator and teach medical students, pharmacy students, graduate students, Master of Science anesthesia students on how to deliver care. And I think that that's really the challenge, because it's not just what I'm doing, it's how I'm setting an example and how I'm teaching the next generation to deliver the care that our patients deserve.
Wonderful. I appreciate the additional perspective. Justin.
Yeah, such amazing perspective from everyone so far. The only thing I would maybe add is that I think our common culture, defines it as what we see in the healthcare space, and knowing that really what defines holistic, health is not, it's only 20% of it happens within the healthcare setting, right? So how are we really supporting that, to Lisa's point, physical, spiritual, emotional, mental well-being and care from all the other 80% of how we interact in our lives? And I think a lot of that is coordination of care too. If we're seeing different models of care being healing centers or trauma-informed care in community-based organizations, how's that coordinated with formalized healthcare, and how can that achieve that trifecta, to Lisa's point? And I think that this discussion today will get at that too.
Thank you, Justin. And thank you, everybody, for your perspectives on this. For anybody in the audience listening, I think you can clearly understand how wonderful this panel is and how much depth is going to be provided in this conversation. Tremendous perspectives from different areas of this state of Wisconsin coming together to find common solutions to eradicating the inequities that remain persistent, consistent in the state of Wisconsin. Thank you all for level setting. So let's just get into it. So in Wisconsin, we know in many communities, we beat state averages and health outcomes, or we exceed national averages and state outcomes. And yet, in this great state of Wisconsin, inequities continue to remain persistent and consistent. What are some historic inequities between those that exist in our communities of color And a two-part question, how has COVID exacerbated some of these inequities? I know you guys know this stuff off.
Yeah. I was like, who's going to go first on this one? So just looking at from like our Indigenous perspective in communities, when I think about historic inequities, that's really, this historic oppression that's been happening since settlers arrived here. And it was their use of institutions that are supposed to uplift the white male that were actually used to oppress us and to remove us from land and remove us from identity. So those systems we don't trust. And there's a historic reason why. We don't trust medical facilities. We don't trust public education. They were used to assimilate and create acts of genocide against us. So I think understanding like that root cause and how far back that inequity goes, and they still use a medical model that is the complete opposite of how we look at and view care. And then institutions today really aren't looking at a holistic perspective. They aren't looking at barriers to care as being racism or any genderedisms. They're looking at, barriers to care is just how do you maybe physically get there, which can be an inequity for Indigenous peoples as well. Indigenous health services are underfunded by half. So, historically, there's this huge underfunding of services, even Western services for BIPOC peoples and Two-Spirit peoples. But it can be a cultural barrier to care, I think, for a lot of us as Indigenous peoples. And that's why you see the grassroots movements. That's why you see the nonprofits forming, so that we can just do the work immediately and not have to go through the policy and the system to say, well, this is what you need to change. This is why we're having problems accessing care. It wasn't made for us. It was made to destroy us. And you're not changing it fast enough. So those are just a few things that I think about.
Thank you. Brilliant perspective on that. And really thinking about generational trust or lack thereof, really driving the success or the inequities of access and quality healthcare. And I appreciate your comments around grassroots immediate responses. I think all across the state, you see a great, tremendous grassroots effort trying to get at the grass tops. So appreciate that perspective. Other folks?
Yeah, I'll jump in. Kristin really framed it just the way that it is. When we look at historic inequities, we have to go to the racialized history, the beginnings of the so-called New World here on the occupied land, right, of Indigenous people, where from day one, the structure of racism and the laws and institutions built to support white culture, white ways of life, and arranging everyone else on a hierarchy that looked very differently in terms of access and opportunity from then to now. And really, I'm broadening that answer to not really talking about the tragedies that we know, but we know the tragedies engulfed in that history from then to now. And we know in the Black community what that racism looked like de facto and de jure segregation, Black codes, deliberate legal steps century after century to disenfranchise a people from having basic access to humanity, legalizing humanity, legalizing how our personhood and our ability to even speak or advocate for ourselves, much less create systems and structures that support our very survival. So bring that to today. This conversation about root causes is the most important conversation to have when we talk about historic inequities, because it helps us understand the present inequities. What we're commonly asked as an organization, I know you're all asked, is, well, how did it get this bad? Why does Wisconsin lead the nation in racial health disparities? Why does Wisconsin lead the nation in racial health and birth disparities and racial inequality across all measures of well-being, be it health, education, economics, justice, all the pieces where we rank worst in the nation, while being one of the highest ranks for other population in terms of healthcare access, quality, lifespan. Wisconsin is the only state in the nation where the life expectancy gap between Black women and white women is widening, and where we see average age of death declining. Here in Dane County, the average age of death for a Black woman is 60 years old compared to 85 years old for a white woman. And you will see that same trend mirrored in our Indigenous community, Latinx communities, and low-income, poor white communities as well. So we have to look at and understand and bring to present what those historic root cause inequities are if we are to solve the challenges that we continue centuries later to experience. We're here today talking about the same consequences and collateral damage that those historic and present inequities are causing in our communities, which is why our presence here today and the organizations that we're representing, that we've created, that we've pushed through generations to have the space and resources to create are so important, because we're legitimately driving the change as we continue to deal with the collateral damages.
Thank you for speaking to the complexities of the issues. Deconstructing all of this is going to take some significant effort and resources. The other two joining us today, any thoughts on this particular question?
Yeah, I think that, you mentioned COVID-19, and I think that for a lot of individuals who haven't been paying attention to health equity, unlike those of us today on the call or on the panel, I think for COVID-19, it was, a recognition or an awakening for some individuals to the to health disparities. Seeing COVID-19 hit certain communities, for example, the Black community harder than other communities, and I think it's sparked a lot of individuals to start asking why. And as you break down health outcomes by zip code, you can see these are the same communities that carry a heavier burden in terms of cancer outcomes, asthma outcomes, infant mortality, maternal mortality, basically every single health outcome there is. And as you start to dig deeper and look for root causes, a lot of terms come up, like quote unquote medical mistrust, or needing to look at the quote unquote social determinants of health. But if you go deeper and deeper and deeper, it all comes down to the same root cause, and that root cause is racism. And I had the privilege to hear Dr. Kamara Jones speak twice at my institution, and she talks about 3 steps. The first step being naming racism. And so I think it's important that we use the correct terms to describe what's going on. The second being, once you name and recognize racism, asking, how does racism manifest itself here? And so understanding this, the structural issues, whether it's, redlining, unethical medical experimentation, understanding what the root causes are. And then third, organizing, developing strategies and acting to overcome, these structural barriers.
Dr. Siker, thank you for walking us through that, starting with the root cause, talking about the social influences that drive medical health outcomes and what you see from your vantage point. And you're absolutely right. Naming it is the first step. And I appreciate your courage to just continue to name it. Justin?
Yeah, I guess just one other perspective on this. If we look at data in so many different ways, it shows us that health is very much tied to wealth, and at the individual level, at the community level, or conversely, poor health is often correlated with poverty. And often, well, in Wisconsin and specifically in Milwaukee, we can see, very stark lines in terms of wealth and poverty based on geography. So geography represents where economic opportunity is and intergenerational wealth is. And then also geography is a proxy for race in our state, meaning, right, we can see that communities are divided by geographic lines based on race and wealth generation. And those are the historic barriers of what caused those segregated areas. And I think that in thinking about how we can allocate resources in communities by zip code level, that granular, and also largely across the state by geography, I think can help us understand how to perhaps combat some of these barriers, because I think that that's a challenge. I totally agree with Malika, I apologize, that racism is absolutely the root cause, but how we get there between there is this inaccess to wealth generation and economic opportunity in order to achieve the highest level of health, however you define that for any community. So I think that that's an important part to just add in.
That's an incredible addition to this conversation. And you guys are making it tough on me because there's so many springboarding questions based off of the comments you made in different directions that we can go with this. Before I get to the next question, something that has come up across all of your answers is racism is a public health crisis. Can you help the audience understand exactly what a public health crisis is? And if racism is the root cause, what is that really meaning for our community?
We're living in a public health crisis. And I don't mean to make light of it, but I think that, to the points made thus far, we've seen that in terms of visualizing disparities and inequities, the Band-Aid's been ripped off through the pandemic, and seen how much worse it can be for communities that are already worse off, meaning people of color, especially in a state like Wisconsin, and also in a hyper segregated area like Milwaukee, where I'm currently living and from. But I think that the challenge is defining racism as the crisis. Also, we're solution makers, right? We want to get to how we can fix things. And I think that that's challenging too, because then we need to know how to address anti-racism. I'm not an expert in that, but I think that the folks that are in power need to have better understanding of how to do that.
Great point.
So, I'm a Wisconsinite. I'm born and bred, proud to be here. From Janesville, went to medical school at undergrad in medical school at University of Wisconsin-Madison, and did my training at Medical College of Wisconsin. And I'm now a cancer doctor, but I'm a radiation oncologist, so I treat tumors with radiation therapy. I'm also a woman of color. And I, working in a predominantly white institution, and grew up and spent a lot of my life in predominantly white spaces. And, one thing I've noticed, at least in my field, the way to move up is to become, a specialist. And then you have to become a super specialist and then a hyper specialist. And I found myself at some point during my training preparing a talk on non-germinous germ cell tumors, and the treatment that I was recommending was like a treatment that you could, like, at the time only get in Switzerland or something. And I was sitting in Milwaukee, just a few miles away, from our hospital, or not even that far. There are communities of color that are facing huge health disparities, and for me it was like, a light bulb went off. Like, why am I spending my time, my talent, my energy, working on problems that are so small in scope, when the communities around us, immediately around us, need our help and our expertise. And I'm very grateful for those individuals that study non-germinous germ cell tumors, in case my child has one someday. But for me, that's not, as a woman of color, that's not where I wanted to spend my energy. And so I became more involved in health equity, diversity, and inclusion. And it just really blew me away to think about how none of this stuff that we're talking about today was ever formally taught to me in school. Health equity was always, just sort of like an afterthought. Maybe there'd be a slide on that here or there, depending on the lecture. The first time I ever really learned about structural racism, was in college, during a humanities lecture that I took. And so I think we need to really start teaching our students. And I know at Medical College of Wisconsin, this is something that we're taking very seriously in terms of developing health equity threads, health equity educational programs that kind of thread throughout the entire education system, so we can teach our students, teach ourselves, what racism is, what a public health crisis is. So, those that develop funding mechanisms can put more of a priority on research and understanding more and coming up with solutions. And so we can teach our students, our current clinicians, to deliver culturally responsive care, for the benefit of our community.
No, that's wonderful. And it also took me back to a time about 8 years ago when I was living in Milwaukee and working in Milwaukee. And myself and the team of community health workers would go over to the medical college to talk to students about the social determinants of health at the time. And it was always a really interesting dialogue. Some were just completely not in tune with the conversation, and some were really excited to have at least that be part of the education. So I appreciate sharing you sharing your personal experience of driving towards the highest level of educational attainment and thinking that was the way that you were going to drive change, and then also having that awakening and really thinking about it in a different perspective. So thank you. Anyone else?
Just what I'd add to that, Gabe, the public health crisis looks like the data we continue to repeat, year after year, study after study. We started counting the studies just in Dane County alone that have been done over the last several decades, chronicling the vast differences in how communities of color experience healthcare, the incredible disparities in health outcomes, chronic illness, birth rates, death rates. That's the public health crisis. And COVID, as Dr. Siker has said, has illuminated the depth and the breadth of those pre-existing inequities that have been chronicled well. For Wisconsin, we've been disaggregating data here by race, income, and zip code for over 30 years, and the data consistently looks the same. And so we frequently say this has been unmitigated, unchanged. And in fact, the data really shows, statewide data and localized data, that the gaps are growing wider. They're not closing, despite the vast technology improvements in care, even with greater healthcare access. We know our communities have less access, that we're more likely to be uninsured or underinsured, but we have greater access to care in Wisconsin than we do in many other states. And even with that access, the level of care, the quality of care, Dr. Siker mentioned, what happens in the relationship between patient and physician or healthcare worker looks vastly different also. Numerous studies stating how Black women, Indigenous women, low-income people, high-income people of different racialized backgrounds, because we know that income is not a protective factor for people of color. So class, education really don't translate into better health outcomes for Black, brown folks. That's a public health crisis. When care is available and accessible by multiple means and the outcomes still show grave disparities. Recognizing that public health threat and recognizing root cause that we've all agreed, racism is the root cause, right, of the disparities and inequities that we see. It necessitates that we take the focus off of individual people and off of communities and flash the light on systems and structures. The accountability really needs to sit with how systems have to name racism, acknowledge its impact, how it's embedded, and how systems run and how they engage with populations of people. And that's where the work of dismantling inequity has to begin. The burden has been placed on communities to figure it out. And we know from our own population health model about the drivers of health quality and health outcomes, the majority of the impact on a person's or a community's health is social, economic, and environmental in nature. It's not whether they go to the doctor on time. It's not whether they eat the right foods or exercise and do all that. That's a small percent. It's about 30% impact. Access to care has an impact. But what is happening in the larger social structural environment around opportunity, economic opportunity, and how systems behave toward populations is really what we need to discuss and reframe our approach to improving care to dismantle these inequities.
I'm trying to remain professional and just really keep it consistent. But I mean, just chills on all of your answers and just hoping that the audience is appreciating the wisdom exchange that is taking place right now on mitigating and eradicating the inequities that remain consistent in Wisconsin. So thank you. And you're absolutely right. Racism doesn't discriminate across economic lines. A famous poet and businessman, Sean Carter, once said in a song, I'm not black, I'm OJ. Okay, right? And so that's America, right? Like it doesn't matter what level of attainment you get to, racism is still alive and present and actively working to keep these institutions, as Kristin mentioned, in place. So thank you for your additional thoughts on that. Kristin, do you want to add anything?
Well, I think Lisa really hit on, like when we talk about a public health crisis, especially in our talks when we're providing education and outreach around missing murdered Indigenous women and all of the intersecting issues that lead up to that larger problem. The point of it is to try and help the public understand, like Lisa said, that this is a public issue. This isn't just an issue that affects BIPOC people or Indigenous people that live in certain areas, that it's a public health crisis because it's affecting the health and well-being of all of us. And it's not isolated to a specific zip code or gender or income level, that it's going to have a grave effect on all of us. And we know that for Indigenous women, our access to care is extremely limited. But even, like Lisa mentioned, when we do have access to care, we're experiencing harm. We're experiencing harm in the medical system. Our traditional birthing practices were purposely removed from us. That was an access to care that had no violence in it. We had amazing outcomes for our babies in our communities. And when it was replaced with this Western system and this Western model, the birth rates went down. And that was intentional. That was on purpose. And I think we have to start looking at that and, like Lisa said, hold these systems accountable. Historically, this is what you did. You may not be removing babies or sterilizing Indigenous women anymore within the medical system, but you're still creating very violent spaces that we have to enter and work in as Indigenous people. It's like, how do you navigate that as a person of color, trying to work within the system, change it within? But you need the allies. You need the systems and the people within those spaces of decision making to get it and to get on board. And it's not that they don't hear us, it's that they're not listening. They're not acting. They're not moving quick enough. So they really need to start looking at, what are your budgets focused on? Are they providing care to the most targeted people with the worst health outcomes? What do your policy and procedures look at for intakes and outreach and education around racism and working with BIPOC and two-gendered communities? So for us, that's like one of our we work parallel with systems. We don't want to become the system. And I think that's why we formed the nonprofit. So we could have Indigenous women care provided by Indigenous women and community in the way that we see it. And that system change in itself. And I think, systems can learn a lot from people of color who have started grassroots movements or nonprofits and how they're doing it, and need to start maybe taking some notes. And how do we change things a little bit quicker? But, education, outreach, and constant action and pressure on systems, I think, is part of the solution.
No, you're absolutely right. One thing that, many things that you said were absolutely spot on. One thing that really resonated with me was this idea about creating harm intentionally, unintentionally, and both, right? And I think it's really critical moving forward in this state that when the decisions are being made, whether it's policy level, provider level, patient level, we really need to think about, are we creating harm? Are we creating status quo? Or are we improving the conditions that are driving healthier outcomes? So I really appreciate that perspective. We could talk about the barriers all day, and Lord knows I have more questions to talk about the barriers. But I think it's an important time that we kind of pivot now and talk a little bit about the solutions or some of the things that you have seen in your worlds that are trending towards working. As we've all pointed out, we haven't solved anything yet in the state of Wisconsin. but there are a lot of great pilots around the state of Wisconsin and grassroots efforts around the state of Wisconsin that are really working. So beyond bringing awareness to the barriers that exist in access to care to the medical profession, how important is it to continue to push this conversation with elected leaders at the local and the state level? What legislation and initiatives have you seen that are really gaining traction or working? It's a lot in that question, so I'm happy to always repeat anything, but.
Yeah, you're going to need to repeat that a couple times, Gabe.
Just really thinking about how important is it, thinking about the decision makers, thinking about how policy impacts people's health and well-being broadly defined. How important is it, one, to continue to push this issue at the state and local level? And two, what is the particular legislation that we need to see or have seen in order to start institutionalizing better healthcare opportunities for our greatest treasure in the state of Wisconsin, its people and its families?
Yeah, I'll just start by saying it's really absolutely necessary to engage our public officials, our elected leaders on the local and statewide and national level. And that is work that I can speak to from the position of the Foundation for Black Women's Wellness and other organizations across the state who've recognized that though we spend tremendous time in communities doing health promotion, education, building awareness, helping folks gain access to care and to better navigate that care, that we have to spend half of our time also advocating for policies that really change the game. And you know, we're in a struggle in that respect right now in our state. There have been many policies set forth to our state government that have been pushed to our legislature. One of the most recent being the Healthy Women, Healthy Babies proposal that Governor Tony Evers put in front of the legislature to really deal with our state's vast and broad health inequities across all measures of health, and specifically to address our first and worst in the nation, Black infant mortality and maternal mortality outcomes across the state, which impacts all of the communities represented on this panel today and others. And there's, you know, resistance is a real issue, you know, understanding at that policy level by legislators who often don't have accurate data, who don't understand the issues deeply, or who politicize the issue based on whatever side of the aisle they feel they sit on. That has been a barrier to being able to pass legislation that's meaningful. We all know the barriers that we face in achieving Medicaid expansion in our state, and all the debates around how that will impact Wisconsin, when we know that it would ultimately provide more care to more Wisconsinites across all of the communities in our state that really need it. But the first step is really educating our legislators so that they can move in ways that really do advance health equity. We're seeing promising things at the national level that are really demonstrating how states need to follow along. There's a federal momnibus package that really is addressing this issue that I keep raising around Black infant mortality, maternal mortality, infant mortality rates, which is a public health crisis in and of itself, where we see folks really advocating for expansion of care, for expansion of doulas, for community health worker models across states, which is your expertise, Gabe, in knowing how mobilizing particular resources in our communities really transform care at the community level, and funding those things that we know that work. We know that the Perinatal Workforce Act was put forth by Senator Tammy Baldwin and partners in our state legislature to really change how the workforce of healthcare looks, and all the issues that Dr. Siker was mentioning in terms of how we're preparing and diversifying a workforce that's ready and able to provide the quality of care that mothers and families need. So there are many, many examples of best practices that are being presented at the statewide and the local level. We spend massive time with our county executive, our mayor, and with leaders, CEOs within our health systems who have incredible decision-making power in shaping how healthcare looks. That has to be a part of the work. A big part of it is education. And what we've learned is that we all have to develop an advocacy and an intentional policy arm in our organizations if we are to really transform health. And so we're learning that on the ground as an organization that didn't start with a policy arm. We've had to move into that space intentionally to really make inroads in changing what we're dealing with at the community level.
Yeah, I think our organization is in that same boat where, we really wanted to keep it focused on healing and creating those spaces of healing that reflected us and looked like us. But you realize that you have to have like this sort of multi-pronged approach to that long-term game. And that definitely includes engaging your leaders, your local leaders, your state leaders, your county board execs, like you said. And you have to, we're persistent about it. It's not just education, but presenting with calls to action. Here's what we need to see and here's how you can do it. And forming those grassroots movements, engaging your community in that, and just giving them the tools to do it. We know as a really small nonprofit, we can't do it alone, but we can engage allies, we can engage community, call your senator, sit with your county boards. They have a lot of power to move resources. You'd be surprised. And then, push for Indigenous women in spaces of elected leadership, get them into those spaces so they can make those changes themselves for our communities. Some of the things that we follow also have to look at resource extraction. So we certainly follow like what's happening around line 3 and line 5, because that's directly connected to our overall health and well-being. Land and water quality it's a direct connection to the epidemic of MMIW. So if we can prevent violence on the land, we're going to prevent violence on the body. So we're really looking at that, and unfortunately, Wisconsin used to have, the prove it first law, which was basically you had to prove that your resource extractive industry was not going to cause any harm. They were not going to pollute, or they couldn't operate here within Wisconsin. That's no longer here. And we've really kind of, the legislature overall in the state has really switched to very pro-extractive industry here in Wisconsin, which brings human trafficking, which brings fines against women. It brings, DV and SA into those areas of resource extraction. So those are things we engage in, as well as the responsive and preventative services for Indigenous survivors and Indigenous women from pre-birth all the way through elderhood. So, we are looking at birthing and women's health and abortion laws and women's rights laws for access to their healthcare always, and working with our legislators to get that change. So it's not as intimidating as maybe people think. We really encourage you. It can be as simple as a phone call, a letter, sending them education, and I think that's the biggest thing, is constant education provided with action. In the long term, it'll make those changes that we're looking for.
Well, thank you, Kristin. Again, just the wisdom exchange that you're providing folks in real time is pretty impactful. And I really appreciate your comments about starting with land and water quality, talking about violence towards the body and getting all the way to human trafficking. This isn't just impacting individuals and just their families. This harm is impacting our whole state, our whole community. So thank you for that.
If I could add, maybe to tie some of these thoughts together, from a public health approach, pursuing health in all policies is really, a strong way to think about, because we're lifting up a lot of different issues that could manifest as different forms of legislation, right? And formally instituting what are called racial equity impact assessments on any bill, a housing bill, an environmental bill, Medicaid, and being able to take any piece of legislation, and that means educating policymakers as much as if folks aren't on board of actually using something like a racial equity impact assessment and having new people in the seats to make those decisions. But taking that analysis, that level of analysis, to see what are the unintended consequences? What are the effects on communities of color to any piece of legislation that's being proposed to really understand? That will dictate whether these gaps can close across various issues that address a lot of the social determinants that we discussed earlier in our conversation, I think.
Great. Thank you for the additional thoughts on that and tying it together. You're absolutely right on that. Dr. Siker, do you have anything that you would like to add to this?
Yeah, I just think that this is a fascinating discussion. It's really hard to add much more after all the really great points that everybody has made. But I just had a conversation with a colleague yesterday, actually. We're in full disclosure. I'm a proud health equity advocate, and I work through many different arenas, whether it's my national medical professional organization, through my institution, through my community engagement, where I agree with this point that we have to keep pushing for all levels, state, local, federal, and health policy is key to that. But I think that advocacy, at least in the medical profession, is becoming recognized as an extremely important tool as physicians to help our patients. And so I'd encourage anybody who's working in the healthcare space to really start to see yourself as an advocate. It's not a question of Democrat, Republican, et cetera. Stay focused on the issues. And if your issue is health equity, let that be your compass. Let that be your North Star as you figure out, which bills you want to support.
That's a great point. I wish we had more time to really dive into that, because I think with the climate of our state legislature currently, we're one of the most politicized groups. And so you're absolutely right. Democrat or Republican, there absolutely is common ground. And actually in Wisconsin, we used to have a place where everybody believed that the first 5 years of life for an individual and their family was one of the most critical investments that we could make in order to set that foundation for success over the life course. And so I think we need to kind of take our flags off of our politicized, fan page and really just kind of figure out what does it mean to be a Wisconsinite, holistically speaking, and try and, create a better environment for health and well-being. In a similar way, but staying a little bit more narrow into the kind of traditional healthcare approach, in what ways do we need to think differently about our healthcare system? You've already touched on, everybody here has already touched on pieces of what we could do differently, but really thinking about an individual or their family experience in accessing and getting healthcare. What do we need to transform how we access or frame healthcare in Wisconsin?
I think within the work that we do, we're looking at it outside of institution or agency, that healthcare is our community, and it's our connection to our traditional foods, our language, our songs, that can be healthcare. It is our healthcare, and it has equal value. I mean, our indigenous knowledge of health, of your mind, body, and spirit is thousands and thousands of years old. So utilizing that with the same value, because we've tend to look at Western models versus Indigenous models. Like the Western models up here, they're the experts. Indigenous is like an add-on, or it's looked at very mythical, or something that's not real or valid because it's not evidence-based. So I think moving not totally away from evidence-based practice, but starting to value practice-based within our communities. And that will increase your access to care, but it'll form a very community-owned ownership in how we build and look at our healthcare.
Thank you. I can share one of my own personal experiences in real time, getting vaccinated at the Ho-Chunk Nation's Wellness Center, and experiencing healthcare from a different perspective was something that I will cherish for a long time. I enjoyed the process. It was a welcoming environment. It was a bi-directional conversation. It was music playing in the background. It was a really joyous occasion, despite everything that was going on with the pandemic and social justice issues. And then I got my second round of vaccines at a big business here locally in Madison, and it felt just a 180 difference. I came in, there was no conversation, it was very cold, and then I walked out the door with my papers. So that's not everybody's experience, but to your point a little bit, there's different ways about customer engagement and customer experience that I think we can really tease out to bring in the whole person's perspective versus this kind of traditional westernized medical philosophy. So just thought I would add that into the equation.
I want to elevate what Kristin said. First, I want to go back and add a point that I missed when I mentioned earlier legislators in our state pushing policies. I did not mention Congresswoman Gwen Moore as a co-author of the Perinatal Workforce Act, which is very important, along with Senator Tammy Baldwin. I want to give Congresswoman all of her just due as a lifetime advocate for health equity in our state. As Kristin said, it's really important that systems invest and community capacity to create their own solutions. The Foundation for Black Women's Wellness exists as a community created solution to address what systems weren't addressing effectively. And so our whole organization is created by Black women, for Black women, centered around the experiences, the histories, and the culture of Black women, and the proven effectiveness of having community-led created solutions cannot be underscored enough. It is organizations like ours, like that which Kristin leads, and others across our organization that are really in the trenches and creating solutions that stick. You know, all the challenges that people say, Black women don't care about health. This is what we heard in the beginning as we were established in our organization. We can't get Black women to show up for appointments. We can't get Black women and families to come out to talk about health. We can't get them in our clinics. We can't. Your approach was wrong because we can't get them there, and they're coming. They're coming, they're trusting, they're taking advantage of the care. They're also transforming into leaders and doers and co-creators of new solutions that they've always had the capacity to do, but they weren't asked, they weren't invited to the table, they weren't consulted, and resources weren't available. And what we know in our communities is whether there's money or not, it has been people in our communities that have created the solutions. I often remark about the Women on Allied Drive here in Dane County, which is one of our communities that's full of life and beautiful people, but it's been historically under-resourced and left behind, right, at decision-making tables and in investments. But Black women, Latina women, other women in that community and other community members have always been in the trenches creating on their own personal budgets, their own wallets, creating ways to supply the needs of their community. They started the food banks, they started the diaper banks, they started the activities for kids. They have advocated with public officials to come and invest and do right by their community with resources and investments, which has to be risen to a level of priority. This can be replicated across our community. There could be many foundations for Black men's wellness. There could be many organizations like Kristin if our priorities were in the right place. A second piece is healthcare and systems partnering with community. Systems exist. They're going to exist. We're not going to dismantle every system. We need systems right now for mass access to services, right? We can't just be rid of systems tomorrow. But how systems develop their relationship with community, like we're doing here in Dane County. One project that we're very proud of with our 4 major health systems here in Dane County is the Saving Our Babies project, which is a deliberate, intentional effort to transform birth outcomes, initially for Black women, given the grave disparities, but for every mother and birthing person in Dane County, and eventually as a model to improve birth outcomes in Wisconsin. This effort was intentionally from day one, one that included and centered Black women, Black men, Black youth as informants and experts on shaping, identifying root causes, and then shaping the solutions And that has been an embedded process, a lens that has been worked into the leadership and the structure of who's driving this initiative, which is now in its third year, about to enter in its fourth, of redesigning how healthcare looks for Black women as they walk into the clinic, of assessing Black women and families, especially high-risk pregnant mothers, for their social determinants of health needs, and connecting and partnering with community-based organizations, doulas, health workers, to distribute that care and to fund those efforts to be able to provide support outside of system walls. It's these type of creative, reconceived, power-sharing initiatives where systems and community have equal footing in driving a solution and sharing resources to make an innovative thing work at the community level is really the direction that we have to move in. So those simultaneous pieces of investing and building community capacity to create their own solutions and institutions while working to create these synergistic partnerships between systems and community, with community at the center. We know that that works. And so replicating that across our communities and state is a best first place to start, in this health equity quest that we continue to be on.
I guess you guys can all see why I enjoy working alongside and being a co-conspirator with Lisa. You just got to kind of be quiet and get out of the way and just enjoy the wisdom exchange. Anyone else on this topic?
Just glad to co-sign everything that my colleagues have already said. And as someone who sits on the other side, working at an institution, it's great to hear in the rooms that I'm in, great to hear a lot of the, discussions about engaging community groups, bi-directional talks, community engagement, community-based participatory work. And just really excited to continue this work and be part of it.
Dr. Siker, I wish we had more time to discuss this, but I'd be curious at some point, or even if you have a quick reflection on if the budgets for like an oncology department or other departments within a hospital and a health system mirrored the budgets for social determinants of health. Do you think that would have an impact in creating healthier outcomes across the life course?
Absolutely. I know, there's some great funding mechanisms out there, like, the Advancing Healthier Wisconsin Endowment, a lot of great places where you can tap in and use the resources. So absolutely, we need more resources, both monetary, but also human.
Absolutely.
Gabe, I have one other thought on that, to both Dr. Siker and Lisa's point about partnering with healthcare. Not only resources, but collaboration. And in Milwaukee, the Milwaukee Healthcare Partnership is really focused on that. It's a public-private consortium of the 4 major health systems. They pool a lot of funding together. They strategically align their community benefit work across systems, and then they try and attack some upstream work. And that's the challenge, I think, is that the partnering with health systems is so important because of the Affordable Care Act. We have a lot of money that's funneled through community benefit offices that are getting recycled back into healthcare systems instead of really integrating perhaps community-based models like Kristin's organization to formalize them and provide the funding to do that. And I think there's a lot of positive change that can be made through redesigning the community benefit models and how they're executed to really engage and center community in that work.
As a former hospital employee, yes, and yes. Thank you for elevating that. We're running out of time here, and I definitely want to wrap up with one final question. And of course, because of my long-winded way, it's going to be a 2-part question, but I'd be curious on all of your thoughts. Before we get to that question, I just want to say thank you all for spending this morning with us. Thank you to Madison 365. Thank you to Henry and all of the staff that got this up and running. This conversation could be a full day summit, this conversation is going to continue on. And I know you all are the leaders, and alongside many other leaders in our great state, continuing to push this conversation both at a policy level, but the reality is for most of you at a grassroots level until we can get it at an institutionalized level. But my final question to everybody, and I'm a pie in the sky, always optimistic type of person, thinking that I can be bold enough to be the part of the generation that eradicates these inequities, despite the generations of great individuals working on these things. But this is a really easy but difficult question to answer. If you had a magic wand and unlimited resources to change the shape of the healthcare systems here in Wisconsin, broadly defined, what would be the number one wish or magic wand deliverable that you would provide? And the second part of it is, if someone who was a decision maker, whether it be in government, whether it be in hospitals and health, whether it be in public health, schools and employment, whatever, if you had a chance to convince a decision maker to listen, what would you say? So what's your magic wand? And if someone was going to take one thing away from you to listen and respond to, what would that be? And I will just start out because I didn't answer any of these questions, but I would love to see reimbursement for community health workers and other care team members that are needed, that are paid for through grants and other, non-institutionalized monetary investments. So magic wand, and then if you had a decision maker who would listen and respond to your wish, what would it be? We all know what the solution.
Oh,
we all have these magic wands.
We only get one. We only get one.
You only get one because we're running out of time. But I know we all have a briefcase or a suitcase or a duffel bag full of them. But
yeah, I think maybe the magic wand, because we are community based, that they would look at that. You would look at what is the community wanting, they're the solution, and then just fund it and give them the resources to do it. The community is the solution. The community is the resource. You just have to get sort of, the barriers out of the way, quit making it so difficult for them, and then support and uplift that. And it would probably be the same for that decision maker, to really look at how are you empowering Indigenous women to spirit within your work. And there's a lot of solutions happening around there. So.
Thank you, Kristin.
I would just ditto that. And there are many magic wands that we want birth inequities to go away. We want babies to be born and to live past their first birthday at the same rate as for Black babies and Indigenous babies as white babies, all those things. But I think it starts with fund the communities to put their own solutions in motion. Trust communities, trust Black women, trust Indigenous women, trust communities of color to know what's in their best interest and fund it. Remove the barriers to funding, put the money in the hands of the people to create the solutions that they need and sustain that funding over time, earmark it in the budget, right? And then, what I would say to a decision maker beyond all the explicit policies, invest in creating the healthcare system, support the healthcare system that you want for yourself and the people you love the most. The healthcare system you want for your child, your spouse, your partner, create that for everyone in Wisconsin. Let that be your measure and let that guide your decisions.
Thank you, Lisa.
Well, since my colleagues have already used their wands on other stuff, I'll use my wand on something that's near and dear to my heart. I don't think we're ever going to get to where we need to get until our healthcare workforce resembles the communities we serve. And so if I had a magic wand, I would ask that we start investing in pathway programs so that every person of color who dreams of being a physician, nurse, scientist, et cetera, has the opportunity to do so, and programs that provide the right support and mentorship for those individuals. And then once they get to professional school, ensure the school is affordable or potentially free. Since it's my magic wand, I'm going to ask for enough money for scholarships for everybody and to ensure that education they're getting is to ensure that the learning environment is equitable, where students can feel they can thrive, feel safe, and bring their whole selves, as well as learn about important topics like those that we discussed today. So that's where I'd use my magic wand, is to develop a knowledge force or workforce that resembles, reflects, and values the diverse communities that we serve.
Justin, thank you, Dr. Siker.
Really wonderful responses. My just quick, pragmatic, in Wisconsin, just full Medicaid expansion, not piecemealed, and getting there through arcane ways, doing that. And then specifically to Dr. Siker's comment, I just had a very poignant workforce conversation yesterday about this, but not just building that pipeline of people of color to work in communities of color in the healthcare field, however you define that, but retention too. That's such an unbalanced system right now that communities of color are feeling like the developers or the workforce developers of strong healthcare providers that are bilingual, that are multicultural, and then they're getting farmed out to health systems that can pay them more money. So how do we create the systems to retain them to work in those communities? And ownership over that work, I think, is very important, not just for the health of the community, but also for the diversity of workforce.
Thank you, Justin. Again, I don't want to stop this conversation, but we are bound by rules of this summit. So again, thank you, Justin. Thank you, Dr. Siker. Thank you, Kristin. Thank you, Lisa. Thank you, Madison 365 and Henry Sanders and his team. This has been a tremendous conversation that was rooted around the historic barriers that are driving the inequities in our community. We've talked about racism as a public health crisis. We've talked about trust, not only about trusting a diverse perspective of voices, but also trusting the patient to be able to articulate how they're feeling and what their health and well-being is, and how culturally relevant their own experiences are in each interaction. We've talked about harm, doing it intentionally or unintentionally, and we've talked about a great need for additional resources to ensure that the grassroots activities are starting to surface to the grass tops. I just am in awe. I'm inspired. My battery has been re-energized, and I just sincerely thank you all for the work that you're doing in the spaces within the state of Wisconsin. Dr. Siker said she was a Wisconsinite, and I think I too truly embrace the role of being a Wisconsinite. I've spent the majority of my life here. I was born and raised here. I went to school here. And so knowing that we have leadership at different levels, at different zip codes within our state is a tremendous reaffirmation that we have people fighting the good fights on a daily basis. So thank you again. I encourage any audience members who have any questions or additional thoughts to reach out to this panel of experts. I know they're doing the work in real time, and I know they're connected to collective impact initiatives that are driving real change. And selfishly, as a collective impact junkie, I wanted to use the magic wand at the end to demonstrate how collective impact is truly one of the biggest solutions that this state needs in order to eradicate these inequities. Everybody brought a different perspective. Everybody brought a different wand. But if we brought them all together, for the older people in the room, we could come together like Voltron and really, truly create something amazing. Thank you very much. Have a wonderful rest of your day, and take care and be well.
This is 365 Media.